Good evening. My name is Dr. Benjamin Felipe. I'm a consultant at the Capital Medical Center. And for this portion of our symposium, going to be presenting how to prevent and control infections in the ICU. Our learning objectives are as follows. I'd like you to be familiar with the methods that can reduce the incidence of the most common infections in the ICU. And for this particular talk, we're going to be talking about the most common infection in the ICU, pulmonary infections, which include VAP, VAEs, and HAP, as well as recommendations for preventing central line infections. First of all, there are no disclosures for me to tell you about. And let's start with a quote from a very famous person who said, "A clever person solves a problem, whereas a wise person avoids it." Our next quote is from someone who is not as famous, but he was during his time. His name is Henry Singerist. He's a Swiss medical historian who was famous during the 1950s. He said that prevention of disease must become the goal of every physician. This is a wise goal for all of us to follow, and it has become one of my mantras as a young physician up to the present time. Now, we were lucky this year to be blessed from the Society of Hospital Epidemiology of America, or the SHAE, with a set of updated guidelines for the prevention of VAP, VAE, and non-ventilator hospital-acquired pneumonia. These came out in, if I'm not mistaken, March of this year. They came up with a list of essential practices for which they have a high level of evidence, meaning they have good studies to back it up. And their number one recommendation is to avoid intubation and reintubation. Of course, if you can help it. Unfortunately, there are some circumstances in which you will not be able to avoid it. Now, what can we do to avoid intubation, or to temporize, as it were, before being able to really put the patient under intubation if necessary? You can use a high flow nasal oxygen or non-invasive ventilation when possible. They have lower rates of intubation, reintubation, and post-extubation failure. High flow nasal oxygen may reduce ICU and hospital length of stay compared with NIV, or non-invasive ventilation. I guess one of the good things that came out from this horrible pandemic is that we were introduced to the possibilities of these new techniques, and experience that was brought about because of this pandemic taught us how to use them. And because of that, our ICU nurses and our doctors have had a lot of experience with it these past 2 years. Another essential practice is when you change the ventilator circuit. In the past, there were fixed days before these needed to be changed. However, now we only need to change them if malfunctioning or if soiled. Changing as needed does not affect VAP mortality. It also can reduce the cost of all of the ICU care. Another essential practice with a high level of evidence is early enteral feeding instead of parenteral. Now, as humans, as animals, we've evolved over hundreds of thousands of years to use our guts as our primary means of nutrition. And that is reflected in our current physiology, which favors enteral feeding. Now, parenteral feeding, if you think about it, is a artificial and not a very good way of feeding a person. For one thing, it's expensive, it's labor intensive, and it can cause a lot of complications. The complication I'm most scared of is an infection because of the problems with the line with which you need to deliver the parenteral nutrition. Another essential practice, but only with moderate evidence, is to provide early exercise and physical conditioning. This shortens the duration of mechanical ventilation, it reduces ICU length of stay, and reduces VAP rates. It will also increase cost savings. Another essential practice with moderate evidence is to minimize sedation. As much as possible, try to avoid using drugs like benzodiazepines. You use analgesics, antipsychotics, and anxiolytics instead. And you also need to establish a protocol, whereas you allow a sedated patient to slowly come up to become more conscious at least once a day to assess his actual level of consciousness. In our hospital where I used to do my residency, we had that kind of protocol. And what we would do is we'd keep the patient under for most of the day, but around the morning, during morning rounds, we'd ask the nurses to lighten up and come up so that we can see exactly where they are in terms of level of consciousness. You should also adopt a ventilator liberation protocol, because if you have a structured way of liberating the person from the ventilator, you can make the extubation earlier rather than later, but by one day. Another essential practice with moderate evidence is daily toothbrushing. I'd like to add that when this particular article came, several newspapers picked it up and reported on it, saying that yes, one of the things you can do to reduce VAP rates, reduce ICU stays, is to make sure that the nurses practice oral care on their patients at least once a day. However, oral care with chlorhexidine is a little controversial. There is a meta-analysis which says that oral care with chlorhexidine might actually reduce VAP rates. But according to expert analysis, it wasn't very well made. It was poorly done. There is another study that also came out that said that according to their findings, it increased mortality rates. So this area is controversial. Right now, what is recommended is oral daily toothbrushing, but without chlorhexidine. So these are examples of this essential practice, which is oral cleaning. And another method of doing it, in this particular patient, you can see that he doesn't have very many teeth left. However, the nurses still should diligently clean their teeth and gently brush their gums. Other approaches include early tracheostomy. Now, this is something that at least infectious disease experts would recommend, and I'm sure all pulmonary doctors would also recommend this, because for one thing, it is associated with 40% less VAP, fewer ICU days, shorter mechanical ventilation. However, it's not associated with lower mortality, but I'm sure that it's going to help to increase the comfort level of the patient by getting a tube out from his throat. Of course, once he's able. Other approaches include post-pyloric rather than gastric feeding, supposedly associated with less aspiration and less pneumonia. However, this is a tricky procedure because special expertise is required and it's not commonly done. So it's only reserved for those who are at high risk of aspiration or with gastric feeding intolerance. Now, there are some recommendations which have been posited over the past, which have been practiced. However, they're not recommended because they provide inconsistent results. And the first one we talked about was oral care with chlorhexidine. Probiotics is a popular medication which is touted by a lot of people. Unfortunately, not many of them are doctors. These are people who say, oh, my relative, my friend took the probiotic and look at him now, he's back to normal. Fortunately, we doctors know that such anecdotal evidence is not really good evidence. And so we really have to wait for good analytic studies. Unfortunately, for probiotics, these are very few and very far between. Another thing that's been touted in the past is silver-coated endotracheal tubes, prone positioning, kinetic beds, chlorhexidine bathing, which have not been shown to have any consistent results in terms of fatality or morbidity. Another one with no recommended proven benefit is stress ulcer prophylaxis. Now, I'd like to stress that stress ulcer prophylaxis in this situation is not recommended if you think that it will help with hospital-acquired pneumonias or VAPs. However, if there is a different indication for stress ulcer prophylaxis, you can go ahead and do it. The other thing that's not recommended is early parenteral nutrition. And as I said earlier, enteral nutrition is best because that is most natural. Now, in March of 2022, the SHA came out with strategies to prevent VAP. In May of 2022, they came out with a list of strategies to prevent central line bloodstream infections in acute care hospitals. I chose this because, well, for one thing, I see a lot of cases like this, and these particular cases can be very deadly. So here is a list of updates of the recommendations from the SHA and, of course, the IDSA and the APIC. They also have a list of essential practices, which are with high-level evidence. Before insertion, it is recommended that you bathe the patient daily with a chlorhexidine preparation. This is in contrast with the guidelines for preventing VAP. For VAP, you do not use chlorhexidine bathing for the prevention of VAP. However, if your patient is going to undergo a central line insertion, then this is recommended. At the time of insertion, the subclavian site is the preferred in the ICU setting. Ultrasound guidance is a relatively safe here in the Philippines. We use it now to look for veins rather than to do lines blindly. And sometimes we also use ultrasound guidance to look for peripheral lines. And it is now recommended as much as possible, if you have it, to do it to improve accuracy and to reduce chances of developing infection. You should use alcohol with chlorhexidine antiseptic or skin prep. Another essential practice with high-level evidence occurs after insertion. You have to ensure that your ICU has adequate nurse ratio and avoid a floating nurse in ICU. A floating nurse is one who doesn't have a fixed patient or maybe might have a fixed patient but goes back and forth between other patients. And that's not a good idea because that's one way that you can start spreading infection. Chlorhexidine dressings are also recommended for central venous catheters. Now, routine replacement of administration sets is recommended, but for up to 7 days. In prior guidelines, it was much faster. However, now it is increased up to 7 days. The exception, of course, is for blood products and lipid products because these need to be replaced immediately. Another thing, and this is for us in infectious disease, is for surveillance for CLABSI or central line associated bloodstream infections. Other recommendations include the use of antibiotic or antiseptic impregnated central venous catheters in adults. I know not all hospitals might have this, but if you have it, it's a good idea to use it. Another thing that any hospital can do is to use antibiotic lock therapy for long-term CVCs. When you're not using the catheter, infuse high-dose or high-concentration antibiotics into your catheter to help reduce spread. And also, when you have it, use antimicrobial ointment or hemodialysis catheter insertion sites. Other recommendations, number one is hand hygiene. I think this is a given and we'll talk a little more about it later. Hand hygiene is important prior to catheter insertion or manipulation. I think at least the nurses have gotten that down pat. Now, it's recommended that use these are great because for one thing, they're aseptic and they have all the possible things that you could need for inserting a catheter. It's better to use a kit rather than to have to go around, looking for the stuff that you need and then gathering them together and then doing a procedure. Because that way you're going to have a higher risk of higher risk of sepsis. Now, another thing is to remove all non-essential catheters. I think that ends up being the infectious disease doctor's job because whenever I round with ICU patients, particularly new ones, some of my residents can attest to, the first thing I look at critically is all of the catheters. What catheters are in, what catheters are not needed anymore. One particular catheter that I have a pet peeve with, although not a central line catheter, is the Foley catheter, which for some reason I call it a fire and forget catheter because it's inserted and then people forget about it and they leave it there and they don't remove it when it can be. And it can lead to a lot of urinary tract infections. And there are some catheters, central line catheters, that are also that way. Fortunately, everyone is more aware now of how severe and how serious a central line infection can be. And so this is not as bad when it comes to central line infection. But then every day, we doctors should assess the need or the necessity for all the catheters that are inside the patient and start removing them as soon as possible. Now, when you do access these catheters, you have to disinfect catheter hubs, connectors, and injection ports before you access them. What should not be considered? Systemic antibiotic prophylaxis for long-term catheters or tunnel catheters is never recommended. Well, not never, but it's not really recommended. There are only a few indications in infectious disease which require prophylactic medications. One of them perhaps is ciprofloxacin to prevent anthrax or to avoid meningococcal meningitis. But otherwise, for the most part, we do not recommend antibiotic prophylaxis systemically as a blanket therapy or a blanket procedure. Now, routine replacement of CVCs or arterial catheters are also not recommended. We don't need to replace them based on a scheduled date or a calendar. They should be removed if they're infected or if they're malfunctioning. Now, I said something earlier about hand hygiene, and as I end, I'd like to end with hand hygiene because it's the single most important infectious disease procedure that we can all use to prevent infection. Hand hygiene, unfortunately, is not something that is still universally carried out by all practitioners, even though it's been more than 25 years since the first recommendations came out. And as I think most of you know, hand hygiene percentages in doctors are poorest for a variety of reasons. In fact, there was an article that came out just this year about doctors' hand hygiene rates plummeting unless they know they're being watched. And there's actually an effect that's been coined for that, the Hawthorne effect, where behavior alteration occurs in response to being watched. So, I guess the only way we can make sure that doctors comply with hand hygiene is to put spies everywhere. Now, it would also help if the alcohol dispensers or the wash basins, whatever that you need for hand hygiene, were more easily accessible. In most hospitals right now, the alcohol dispensers are located outside the patient's room. However, if you do hand hygiene outside the patient's room, and then you open the door, then your hands are contaminated again. Ideally, the best place to put the alcohol dispensers is at the point of care, and that would be by the patient's bedside. That way, it'll be easily seen, and then once the patient performs hand hygiene, his hands will be ready to examine the patient. Anyway, as I said earlier, in all hand hygiene studies, poorest rates of compliance were among physicians. And I've been looking at all these studies. These studies date back to the early 90s and the late 80s. Universally, almost, poorest rates were among physicians. I hope that we can change that. In conclusion, I'd like to say that some of these interventions require expensive devices or equipment, but not all. There are a lot of interventions which require very little and are not very expensive. For example, as I mentioned earlier, hand hygiene. Other things include oral care for patients who are in the ICU. Unfortunately, these preventive measures don't have a good ROI or return of investment. So I don't blame hospital administrators for being a little reluctant to spend money on procedures or equipment which will not show a measurable or accountable benefit. However, the benefits are tangible if only through studies. So I do recommend that at some point, um, our hospital administrators open up their eyes and provide us with more funds to do more proper or better hand hygiene and other interventional procedures. This is Dr. Benjamin Felipe. I've been your lecturer for today. Thank you very much. And I believe after this lecture, I'll be entertaining some questions. Thank you and good evening.